Thank you. It's a pleasure to be here. I will give a talk for probably only about 30 minutes, and we're really going to talk primarily about the basics of stroke. And then I want to leave plenty of time for people to ask questions about topics of their interest. Stroke is a very broad topic, lots of different research going on, so hard to summarize it all in a short talk, but be happy to address anything that's on your mind. So you heard a little bit about me. I actually came to Stanford first in 1984, right after graduating medical school. Came up here for my internal medicine, neurology training, and then a stroke fellowship. So I've spent my entire career, 30 years here at Stanford. Have never looked for a job elsewhere because I love being here. It's a great place to interact with other physicians and have a team approach to taking care of patients as well as doing research. And as was mentioned, we formed the Stanford Stroke Center in 1992. I began on the faculty after finishing my training in '89. At the same time, Gary Steinberg, who's a neurosurgeon, was just finishing up and starting as a new faculty member in neurosurgery with an interest in stroke. And Michael Marks was a young guy who was interested in putting catheters up into the brain to try to treat stroke. So he was a radiologist, I was a neurologist, and Gary was a neurosurgeon. And the typical approach to stroke back then was that those three groups did their own thing, that they didn't work together, that they worked independently with what they could offer. And the idea that we had is that it would be a novel approach to work together as a comprehensive type of team where we could try to use the approach of the team rather than the individual to treat patients. And Stanford Hospital was very welcoming to that idea to give it a try, gave us some funding to try to start the program together. And all three of us have stayed around for all this time because we really enjoy doing stroke research, taking care of patients, and trying to train individuals who want to make a difference in stroke. So we have medical students, residents, fellows who are training to be stroke specialists, and now they've moved on to different places to start stroke programs. And now it's in vogue to do comprehensive stroke center, to have multi-collaborative approaches. And they're doing accreditations now for comprehensive stroke centers. So we were very happy to be the first in the country to be chosen as an accredited comprehensive stroke center. So that's the background on the center. And now what I want to do is just give a bit of an overview about stroke, how to prevent it, how to treat it. And then we'll end with a case example of somebody who recognized a stroke and alerted us to it right away so that we were able to treat her husband. And you can kind of look at the different impression of a stroke in somebody who's having one versus somebody who's watching one. And hopefully by the end, you guys will be ready so that if you see somebody who's having a stroke, you're going to know what to do. All right? So stroke is a big problem. It used to be the third leading cause of death. It is now the fourth leading cause of death. But death is really the least of the problems with stroke because most people with strokes don't die, but most people with strokes are disabled. So what people typically fear most about stroke is not that they're going to die from it, but it's going to be disabling and that they're going to wind up in a nursing home or not be able to do the things that they liked to do before because of the injury to the brain. Stroke continues to be very common. It's become a little bit less common because of the treatments that we've had for risk factors, particularly high blood pressure, as we'll talk about. So that the chance of a given individual to have a stroke is actually less now than it was a few years ago because of risk factor control. But the population, of course, is getting older. Baby boomers like myself are starting to head up into the stroke-prone age groups. So that means that even though we have a little bit better control of the risk factors, the number of strokes that we anticipate over the next 2 decades is very high, and that we're going to go well above the 780,000 strokes that occur right now in the US every year. So this is a huge problem, and I suspect that all of you have had your lives touched by stroke in one way or the other because you're here. But even if you go to a general audience, you'll find that most people, usually about 1 out of every 3 individuals, has had their life touched by stroke, either because it's a family member, them themselves, or somebody very close to them. So incredibly common. And this is one of the things that drew me to stroke, that it was not treatable at all when I started, and that this was such a common problem that it was something we could really get excited about trying to make a difference. So let's look at a little bit of the prognosis after stroke. As I mentioned, stroke is not a major problem in terms of a given individual who's having a stroke is relatively unlikely to die from it. Even though it's the fourth leading cause of death, it's only about a 15% chance that you'll die from the stroke. The type of strokes that are most likely to cause mortality are the bleeding type of strokes, the hemorrhages, and we'll talk about that. The strokes that also can cause mortality are when you have a very large ischemic stroke, and we'll discuss that as well. But usually what we're looking at is rehabilitation, recovery, and that the brain can rewire itself, which again is something new that we didn't realize when I was in training, is that the brain has the potential for rewiring, and that with patients and with therapy, that most patients will make a lot of improvement, particularly in the first several months after a stroke, but the improvement can go on for many years after the stroke. Stroke is one of the most costly medical diseases, not just because it's expensive when somebody's in the hospital, and they may be in the hospital for many days or even weeks with a stroke, but it's because stroke can hit at any age. And even though it's more common in older patients, many people who have a stroke are still working. So then you're looking at not only the cost of the stroke itself, but you're looking at the cost of the lost productivity from the person. And people who have a major stroke with major disabilities, then you're looking at nursing home care. So it really adds up to being one of the most expensive medical conditions that we have. Okay, so time for some audience participation. Who can give me a definition of what a stroke is? Right here.
Loss of oxygen to the brain.
Okay, that's a good definition. Loss of oxygen to the brain is what was said. Anybody want to add to that or take a little different approach?
Maybe a blood clot in the brain?
A blood clot in the brain, that certainly can cause a stroke. Any other definitions?
Paralysis of certain limbs?
Yeah, that's one of the things that stroke is going to do, cause paralysis. So, hemorrhage, absolutely. Bleeding in the brain is, in addition to a blood clot going up into the brain and blocking off the blood flow, a blood vessel rupturing and causing hemorrhage is a stroke. So you can start to get the feeling from the responses that stroke is not totally straightforward, and it is complicated. So the definition that I like is that stroke is the brain injury that occurs when there is an abrupt disruption of the blood flow to the brain. So that abrupt disruption of the blood flow to the brain can cause for two major reasons, and you guys hit on both of them. One is that the blood flow is blocked by a clot, that a clot comes from somewhere or is formed in the brain, and it prevents the blood from flowing into the brain. The other cause of stroke is a blood vessel that ruptures. So then you either get bleeding into the brain or around the surface of the brain. And you can imagine those are very different problems, right? A blood vessel that's blocked up with a clot, we're going to approach that very differently than we would approach a blood vessel that has ruptured and now has blood spilling into or around the brain. So two major problems. Which one do you think is more common? Absolutely, absolutely. This is much more common. So we're going to focus on this, but we'll talk briefly about some of the ruptured arteries. So ruptured arteries, there's two major flavors here. One is that it's a blood vessel within the substance of the brain that ruptures, and this is a CT scan, which is an X-ray picture. This white blob is blood bleeding into the brain. Patient didn't make it, and you can see the blood here in the center of the brain. So this is a blood vessel that's piercing into the brain, which ruptures. And why do you think that might happen?
Accident?
Yeah, so an accident usually will cause some injury to the surface of the brain, but a blood vessel deep in the brain usually ruptures for a different reason than an accident.
An aneurysm?
So an aneurysm is a good reason for a blood vessel to rupture. We're going to get to that in a minute. The aneurysms usually form at the blood vessels at the base of the brain. But a blood vessel that's piercing deep into the brain typically will rupture because of many years of high blood pressure. That many years of high blood pressure pushing against the surface of that blood vessel wall weakens the blood vessel wall, and one day it gives way and starts bleeding. So if we could control everybody's blood pressure we would see very few of these hemorrhages because the vast majority of these deep in the brain hemorrhages are caused by high blood pressure. There are some other unusual reasons, like having an abnormal cluster of blood vessels in the brain that we call an AV malformation. Certain drugs like cocaine or amphetamine can cause blood vessels in the brain to rupture, but hypertension is the one that we could really make a huge difference if we controlled it. So the aneurysm, which you guys mentioned, causes what's known as a subarachnoid hemorrhage. So the aneurysms sit actually on the surface of the brain. They sit in an area called the circle of Willis that we're going to talk about in just a few minutes. And when they bleed, the blood goes all around the surface of the brain. So you can imagine this is something that the brain doesn't like to happen, to be covered in blood, because blood is very irritating to the surface of the brain. So having blood in the brain, like in this example, or having blood on the surface will cause bad headaches, right? So typically somebody who's having a bleeding type of stroke will have a severe headache, often the worst headache of their life. Now that's going to be very different from the more common types of stroke that usually have no headache or very mild headache, which are the blood clot blocking off blood flow. But these more serious brain hemorrhage are typically going to present with neurologic symptoms and a very, very bad headache because of that blood. Okay, let's now shift gears, and we're not going to talk so much about the bleeding types because that's only about 15% of strokes. About 85% of strokes are when you have a blood vessel either in the neck or in the brain that's blocked off with a blood clot. So we need to know a little bit about the anatomy to understand stroke. There's two sets of blood vessels that bring blood to the brain. The anterior circulation, the front circulation, are the carotid arteries. And these are very easily accessible. You actually can feel your own carotid if you put your finger just below the angle of the jaw. And don't press too hard there, but if you press gently, you can feel the carotid artery right here, which is pulsing. So you've got one on either side going up the front of the neck. In the back of the neck, you have the vertebral column, and you have the vertebral arteries. And if you look at the picture, you can see that these blood vessels actually go through little holes in the spine, and then the two sets meet together to go up to the brain stem. So the carotid arteries are going up to the hemispheres of the brain. The vertebral arteries are going in the back towards the brain stem. Now, these two sets of blood vessels come together with what's called the circle of Willis. So you see this circle here, it links the two together. And it's very nice if you're born with a good circle of Willis, because what that means is that if you have one blood vessel that's blocked up, that you can get help from the other blood vessels. That's known as collateral circulation. It means one blood vessel can help out another one that's blocked up. And some people can block off the whole carotid artery and not have a problem because the other vessels are helping out. Some people can actually block off both of their carotid arteries. The biggest blood supply to the brain slowly blocks off, and the other vessels in the back can take over. So the circle of Willis is important. Then how the blood vessels come together on the surface of the brain to help each other out is also important. These are things that we don't have control over. This is how you were born. You're either born with a nice circle of Willis or not, and you're born with a nice collateral circulation. It doesn't necessarily matter how old you are, but how you were born. So you can thank your parents for if you had good collaterals or not. There's things that you can do to make the collaterals work less well, like smoking cigarettes will block up the collaterals. Having high blood pressure, high cholesterol will block them up, but you're kind of born with a set of collaterals. So one of the things that you can imagine is since these blood vessels go to different regions of the brain, the symptoms of the stroke are going to be quite different depending on what blood vessel is blocked. So we'll talk a little bit about that. First, we'll show a little bit more detailed picture of what the circle of Willis looks like. You can see there's a whole bunch of blood vessels that come together to make this circle. We can take pictures of that to try to understand when somebody's having a stroke, what other blood vessels are going to be available to help out. Okay, so let's get into the symptoms. The symptoms depend on what part of the brain is involved. Symptoms of a stroke are much more complicated than symptoms of a heart attack. If we're talking about the stroke that is due to blood clots, we refer to that as ischemic stroke, which means there's no bleeding in the brain. And if there's no bleeding in the brain, it usually doesn't hurt. Okay, so that's one of the disadvantages for stroke compared to heart attack. If it doesn't hurt, people are much less motivated to go to the emergency room. Right? Stroke also frequently occurs in the middle of the night. So you're asleep and you don't notice it because it doesn't hurt. If you had a heart attack in the middle of the night, it would wake you up from sleep. The brain is very complicated. So the right side of the brain is going to be doing things that are very different from the left side of the brain. So the hemispheres of the brain are primarily fed by the carotid arteries. We call that the anterior circulation. The brain stem and the cerebellum, which is a coordination area, are primarily fed by the vertebrals. We call that the posterior circulation. So depending on what blood vessel is blocked up, the symptoms can be incredibly variable. So what would you expect might happen if you blocked off the left carotid artery? What kind of symptoms? Yeah, so we heard language, and that's right. Most of the language function for both left-handers and right-handers is in the left hemisphere. So, and then heard numbness. So what side of the body would be numb if you blocked off the blood flow to the left side of the brain? Right. And in addition to numbness and language trouble, what else would be a prominent symptom? Somebody mentioned it earlier. What's that?
Vision loss?
Vision? Yeah, vision can be lost because the carotid artery is going to supply the blood supply to the eye on that side. So if your left carotid is blocked, you may have some trouble with your left eye. It is also supplying part of the visual areas that look at the right side of the world. So you could be missing vision from the right side of the world or the left eye if your left carotid was blocked. But one of the most prominent symptoms is going to be weakness, right? And people mentioned that before. So it's the right side of the body that's going to be weak if you have trouble in the left hemisphere. And the weakness from stroke normally comes on abruptly. It's not the type of weakness that builds up slowly over days, weeks, or months. It's the type of weakness where you're absolutely fine 1 minute and then you can't move the arm the next moment. So it's abrupt onset because when that blood clot blocks up the blood flow, suddenly the function stops. Doesn't mean the tissue dies right away, but suddenly the function stops. So the symptoms come on very quickly. So somebody with left carotid stroke may not be able to speak, or they may not be able to understand words. So they may be able to make no words, nonsense words, or have trouble getting the words out. They may also have trouble understanding what you're saying. So when you're talking to them, it sounds like you're talking a foreign language. So that if you ask them to do something like close their eyes or lift up their arm, they won't because they can't understand what you're saying. So different language areas in different parts of the left hemisphere can affect the patient differently. So it could be very mild, where they're just having trouble finding the right word or saying a few nonsense words, all the way to what we call a Broca's aphasia, where you can't get any words out. You become completely mute. Okay, now on the right side of the brain, there's usually no language function. Some left-handers will have some language function on the right side, but what they will have would be the control of the left body. And they have something called neglect, particularly if it's kind of the mid portion, what we call the parietal lobe, which means they don't realize they're having a stroke. Okay? So people who are having a stroke in the left hemisphere usually can't tell you about it very well because they can't talk. So they can't call 911 and say, I'm having a stroke. People having a stroke on the right side, they don't think they're having a stroke. So even though they could talk and call 911, they see no reason to because they don't realize that their left side is weak. So they often will be confused, but neglect means that they don't realize what's going on, that they can't tell that their left arm is not working or the left leg is not working. They just seem to be, thinking that it's not even their own arm sometimes. Even you can lift up their weak left arm and say, whose arm is this? And they say, well, that's my Aunt Tilly's arm, or that's your arm. They don't even recognize that part. So again, you can see why we have trouble getting people in, because stroke has a lot of complicated different symptoms, and then it's hard for the patient who's having a stroke to call 911. So somebody else has to do it, right? Stroke in the back part of the brain can be very confusing also, because sometimes it doesn't have as dramatic a presentation with the weakness and the language trouble. It may just be double vision. They start seeing double. Or it may be some vertigo. Things are spinning around and people are off balance. They're trying to walk and they wind up leaning to one side. Or the coordination goes off when they're trying to use their arm or leg. So different symptoms. And sometimes it can be very dramatic, where you have the right and left hemisphere are all funneling down through the brainstem. So if you have a bad stroke in this posterior area, you could lose control of all four extremities, which we call a quadriparesis. You can't move your arms, you can't move your legs. And if it's really, really bad, it may be the only thing you can move is to move your eyes up and down, which is called a locked-in syndrome. So again, it could be anything from very subtle, a little bit of double vision, a little bit of unsteadiness, to all the way to having no movement in the arms or legs. So it's not so easy to figure out that somebody is having a stroke from other conditions if they're having some of the subtle symptoms. And sometimes, even the neurologists are puzzled in the emergency room. So oftentimes we're going to have to do some imaging to sort it out. But you can see what the main symptoms are. The main symptoms are going to be trouble with the language, weakness on one side, numbness on one side, headache if it's a bleeding kind of stroke. So if you have those symptoms coming on abruptly, that should be a key to call 911. Okay, so what's going to cause a blood clot to block off a blood vessel and cause a stroke? Well, most of the causes are summarized here. The number one cause is atherosclerosis, also known as hardening of the arteries. So it's the same process that causes a heart attack. It builds up cholesterol, plaque in the blood vessels of the heart, and that's going to cause a lack of blood flow and a lack of oxygen to the heart. If it does it on the way to the brain, it's going to cause a stroke. So this is the aortic arch that comes off the heart. This can develop atherosclerosis. Here's the carotid artery. Here's the blood vessels in the brain. Atherosclerosis can happen anywhere along this tree. That's the number one cause of stroke, atherosclerosis. Next most common is going to be an embolism from the heart. An embolism means a clot that started in one spot and it travels somewhere else. So the most common heart condition that could cause a clot to form in the heart is called atrial fibrillation. So atrial fibrillation is when the top chambers of the heart, instead of beating nice and regular like this, start to do this. They fibrillate. So the blood swirls in the top chambers of the heart, and swirling around, it can form a clot. The clot can then break loose, and the favorite place for it to go is up into the brain. So patients with atrial fibrillation are at risk of stroke, and we have treatments to prevent them from having a stroke. If you have a sick heart valve, that can be a spot where a clot can form. A sticky heart valve can form a clot, and if you have a big heart attack, then the main pumping chambers, the ventricles aren't working very well. The blood can also swirl around there and form a clot. So when somebody comes in with a stroke, we're thinking about, let's take a look at the blood vessels and look for atherosclerosis. Let's take a look at the heart and see if we've got something going on with the heart that could predispose to a clot formation. And if that's not the cause, then you can start thinking about the blood, right? What if the blood gets too sticky for some reason? Sticky blood could form a blood clot, and the blood clot then could cause a stroke. So a variety of causes, but most of them relate to the blood vessels, the heart, or the blood itself. Okay, so number one cause of stroke is atherosclerosis. So we're going to show a movie to show you how atherosclerosis progresses over time. And unfortunately, everybody gets some. There's no way to go through a long life and not develop some atherosclerosis. In fact, even when you look at soldiers who die in a military accident, if you look at their blood vessels, you'll start to see the beginnings of atherosclerosis. So we all have to deal with it a little bit one way or the other. So here is a speeding up over what one might see over many, many years. Okay, so this is the blood vessel, and this is where the blood would travel. And this is the atherosclerotic plaque building up. And what do you think is in this plaque?
Don't you need an infection to start that?
You don't need an infection to start that. Having infections may promote some atherosclerosis, but infection's not the biggest cause of atherosclerosis. We'll talk about the risk factors in a minute. But what do you think is in that plaque? This is not, there is some inflammatory component, but that's not the main component. Cholesterol, exactly. So what we're seeing here is a buildup of cholesterol on the wall. And if you look carefully, you would see some inflammatory reaction. So the cholesterol itself is really not such a huge problem in this stage. It's well contained. This is called the endothelium, the inside lining of the blood vessel wall. And as long as this endothelium is smooth and shiny and not sticky, it doesn't matter so much that there's cholesterol building up here, okay? Because it can't really do much as long as it's encased in this smooth endothelial lining. The blood here does absolutely fine until you block off about 70% of the area here, right? So here is less than 50% blocked. There is no reduction in blood flow here. Blood flow is getting in just fine. If this gets to the point where it's starting to block 70, 80, 90%, it's going to start to reduce blood flow. So it's like a plumbing problem, not enough blood flow. But that's not usually how atherosclerosis gets you. Usually it's what we're going to see here is that before it blocks off all the vessel, the plaque is going to rupture, okay? So you see this spot here? This is the lining. The lining is now ruptured. This is called plaque rupture. This cholesterol material is extremely sticky. So when this cholesterol material comes in contact with flowing blood, what's going to happen? And here we go. All right, comes in contact with the blood. Boom, we form a clot. So that clot can do what it's done here and completely block off the blood flow. Now we have a completely blocked vessel, or if it doesn't completely block it off, pieces of that clot may break loose and head up into the brain. So this is what we're fighting against, is progression of atherosclerosis. So causes a stroke, atherosclerosis in the large vessels, meaning the ones we talked about in the neck, about 25%. Atherosclerosis in the small vessels, vessels in the brain, about 20% of stroke. 20% are clots that form in the heart from atrial fibrillation or other heart problems. 15%, we talked about bleeding in the brain or bleeding in the subarachnoid space. And look at this. Even now, when we do a very detailed evaluation, we take pictures of everything, 30% we don't find the cause. Cryptogenic stroke is what we call it, or idiopathic. Some people say idiopathic means the doctor's an idiot. They couldn't find it, right? And this is frustrating for the doctor. It's very frustrating for the patient because the patient wants to know, why did I have a stroke? It's actually a good thing overall because the prognosis for having another stroke is quite favorable if you've been very thorough and you found no cause. So even though the patient's not happy, overall it's a good sign. If you find that the vessels are all blocked up, you can imagine the prognosis is not as good, but sometimes you can deal with that, get the vessels cleaned up. And usually the heart conditions can be dealt with pretty well, so that if somebody's stroke came from the heart, typically we can find ways to prevent it from happening again. Okay, so lots of stroke is caused by atherosclerosis. Atherosclerosis affects the vessels in the heart in a similar way to the vessels in the neck and the brain. So no surprise how to prevent them, right? You've all heard this before. Cigarette smoking promotes atherosclerosis. It makes the blood vessels stickier. It makes the blood vessels narrow. So this is one of the biggest, most treatable risk factors, because treating it is can reverse the situation with a lot of the damage to the blood vessels. Alcohol abuse is a problem for stroke for a number of reasons. It can cause heart rhythm problems. It can cause increased risk of bleeding in the brain, and it can cause an increased risk of blood clots forming in the brain. So heavy alcohol use is a bad thing. Drinking a glass of wine a day is slightly protective. Right? So it's not a recommendation to start drinking if you don't drink, but drinking a glass of wine is not a risk factor for stroke. Actually, it may reduce stroke risk just a touch compared to people who don't drink at all. But drinking too much is a big risk factor. Physical inactivity, lack of exercise is a risk factor. And then the whole host of the usual medical conditions. For stroke, high blood pressure is the most important. It's the most powerful, prevalent risk factor for a stroke. So again, both for the atherosclerosis type of strokes as well as the bleeding in the brain type of strokes, this is what we could do to prevent them most, and that would be control everybody's blood pressure. Atrial fibrillation we talked about. Cholesterol is obviously what's building up in the blood vessels, and patients who have diabetes have more atherosclerosis faster than people who don't have diabetes. So getting good control of the diabetes is important. If you've had a stroke, you're at increased risk for having another one. So again, we need to try to sort out why did that stroke occur and what can we do to prevent it. So a transient ischemic attack is a TIA. Who knows what a TIA is? How would you define that?
A piece breaks off, but the blood venges to destroy it before it ruins the brain.
Oh, I like that definition. So you've got a blood clot that's gone into the brain, And before any injury to the brain has happened, your body dissolved that blood clot. You have little enzymes in your blood that try to dissolve blood clots. And if it dissolves it before it does any damage, it's a TIA. So the symptoms will be the same symptoms of stroke, but they'll be brief. 10, 15, 20 minutes would be typical duration of symptoms. And we know it's a TIA by taking a picture and seeing exactly what you said. There's no injury. If the symptoms last for 20 minutes and we take a picture and we see that there's a little bit of injury, then it's a stroke. Just like a heart attack versus angina. A heart attack is when you've damaged some heart muscle. Angina is when you've got chest pain because not enough blood flow to the heart, but you didn't damage any heart muscle. And what you can see is that if you've had a TIA, the risk of having a stroke in the next 2 days is 5%. Okay? So what does that tell you about a TIA? Better not ignore it, right? It's not the type of thing you schedule an appointment in a week and tell your doctor that you had a 20-minute episode where you couldn't lift your arm, or you had a 15-minute episode where you couldn't talk and the right side of the body was numb, because the highest risk time is in the first couple of days. So we want to see these patients get into the emergency room. We want to have them evaluated very rapidly if they had the symptoms of a stroke, but they disappeared. So what are we going to do? Well, if you control the blood pressure, you're going to reduce your stroke risk by up to 40%. That's huge, absolutely huge, to reduce stroke risk by 40%. So if you're somebody at high risk of stroke, 10% per year, you could reduce it down to 6% per year just by getting the blood pressure under control. Smoking is amazing, that people who've been smoking, even if they've smoked for many years, if they stop, they can cut their stroke risk in half within a year of stopping smoking. So incredibly motivational to, it's hard to stop smoking, but a huge payoff if you stop. And the risk from smoking goes almost away after 5 years. If your cholesterol is high, your stroke risk can be cut down by about 20% by using these statin medications, okay, like atorvastatin or Lipitor is a popular one, or simvastatin, pravastatin. These are medicines that reduce cholesterol and probably have other beneficial effects that we'll talk about in a minute. And look at blood pressure. So here's a graph that shows you the relationship between cardiovascular events and blood pressure over a 15-year time period. So this includes both heart attacks and strokes. And you can look at the rate of heart attacks and strokes in somebody whose blood pressure is in the 140/90 type of range, 130/85, and 120/80. And you can see that the lower the better. So that lower blood pressures, lower risks of cardiovascular events, particularly stroke. So what we like to see is blood pressure is getting down towards 120/80. If people are spending a lot of time up in the 130s or 140s, that's too high. Okay, so eventually you get to a point where you can't go too low. You go too low with your blood pressure, you pass out. But most people, even elderly individuals, can tolerate blood pressures down in the low 120s, and for the top number, the systolic and the diastolic, down close to 80. And that's what we try to shoot for. And particularly somebody who's had a TIA or a previous stroke, we're going to be pretty aggressive about trying to get the blood pressure down. We talked about the cholesterol medicines, these statins. These are often very controversial medicines that patients have a lot of rumors that they've heard about, that these are going to cause their muscles to dissolve or their liver to cause problems. But these medicines seem to have benefits above and beyond just reducing the cholesterol. They have what are called pleiotropic effects, which means that they help preserve that endothelial cell layer, that smooth layer that's helping to protect that plaque from rupturing. So that there's benefits from these agents in many ways, but we want to see the cholesterol down. Did a big study many years ago called the SPARCL study, where we took patients who'd had a stroke. We put them on a high dose of this atorvastatin medicine, Lipitor, which is a common statin, 80 milligrams. And many of the patients were nervous, oh, that's too high, it's a big dose. And the other comparison was the placebo. Right? So big dose of atorvastatin versus placebo. And the number who complained of muscle aches in the statin group was identical to the number who complained of muscle aches in the placebo group. So the conclusion is, at our age, everybody's got muscle aches, right? And we like to blame it on something, so patients like to blame it on these statins. But the statins really don't cause muscle aches a lot more than than not taking a statin. There's some very small risk it's going to irritate the liver, so you need to check blood tests periodically to make sure that it's not doing that. But most people tolerate these medications very well. So virtually everybody who comes to the hospital with a TIA or an ischemic stroke is going to expect to go out on one of these statin agents unless their cholesterol is really low on its own. And just like blood pressure, what the studies have shown is that the lower the bad cholesterol, the better. So the LDL cholesterol, we used to think get it down to 120, then 100. Now we're targeting more like 70 or 80 for the LDL, bad cholesterol, again, particularly in people who've got evidence of atherosclerosis. We'd had a hope that giving estrogen replacement to postmenopausal women who had stroke would help them have a lower rate of stroke. And when we tested it, we found it didn't work. If anything, it made things worse, so that the estrogens can make the blood a little bit stickier. So that's not something that we do for a postmenopausal woman who has a stroke. And even somebody on birth control pills is at a little bit increased risk of forming clots in their legs or having a stroke because the estrogens can make the blood a little bit stickier. So how do we make the blood a little bit less sticky? Well, here's a detailed picture, schematic, looking at blood clotting. So blood clotting involves something called platelets, which become activated when you have injury, right, to help you form a blood clot. But they can also be activated by that cholesterol plaque. The atherosclerotic plaque can activate the platelets, and they can trap blood cells in this fibrous net to form a blood clot. So taking a medicine that makes the platelets less sticky can reduce the chance that a blood clot is going to form on a sticky surface. So the most famous, aspirin. It's a good medicine to make the blood less sticky. Then we have other prescription medicines like Plavix, which is clopidogrel, or Agranox, which is a combination of dipyridamole, which is another prescription medicine, and aspirin. They can make the blood less sticky. If you have a blood clot that's forming in the heart, usually aspirin is not enough to prevent that. So somebody with atrial fibrillation, we're going to use a stronger type of blood thinning medicine that we call an anticoagulant. The most famous is Coumadin. Now we have 4 new prescription medicines that have some advantages over Coumadin as more potent blood thinners. And if you have to give it intravenously, then it's medicines called heparin. Okay, so how are we going to choose? What we need to do is the patient comes in and we need to sort out why they had the stroke. Sometimes there's rare causes that we don't have time to talk about tonight, but most of the time you're going to find out that the guilty party is atherosclerosis, or it's a problem with the heart, or as I said, about 30% of the time we don't figure it out. If we don't figure it out, we treat it as if it's atherosclerosis, and we assume that there may be some mild atherosclerosis that we couldn't find, that we just didn't have sensitive enough tests to pick it up. So these patients are typically going to go out on antiplatelet therapy. So the least expensive is aspirin. Clopidogrel, which is Plavix, is also a popular choice. If it is a problem with a heart valve, atrial fibrillation, a heart attack forming a blood clot in the heart, then typically we're going to use one of these more potent anticoagulants. And you can imagine those are a little more dangerous. They have higher bleeding risk. They need a little bit more monitoring in general. So those are the typical choices. Here's some studies. We've been involved in several of these over the years, saying that if you have one of these heart conditions like atrial fibrillation, that aspirin works, but the stronger blood thinners like Coumadin, which is also known as warfarin, they work better. Okay? The way that warfarin was discovered is that this is a medicine that can cause rats to bleed. It's rat poison. Big dose of warfarin, and the rat dies and they bleed. So some patients don't like this because they don't like us to prescribe rat poison. And as I said, now we have newer agents that don't have that checkered history that work even better than warfarin and are very safe options. Now, the other thing you can do is try to pull the atherosclerosis out. So here's the surgical option, which is called carotid endarterectomy. This is a picture of somebody's carotid. Like in that video I showed you, this, is blocked up with one of those cholesterol plaques. You can cut it open and carefully dissect it off. The other approach is you can go up there with a balloon and you can squish it against the wall and put a little metal stent in there, which is called carotid stenting. So this would be an approach if you had a minor stroke or you had a TIA and you find out that that carotid's blocked up, we're probably going to want to think about cleaning that out. And here's an actual picture of what this looks like. So, the years of Haagen-Dazs and peanut butter and potato chips, you can see the remnants here have wound up in the carotid artery. And what's this red thing? Blood clot. Yeah, so that's the platelets that have formed this clot. And it's really a combination of the cholesterol plaque and the clot that's causing the trouble. So how to prevent a stroke? We're going to control the treatable risk factors, high blood pressure being the most important, diabetes, smoking, cholesterol, exercise. You're going to take an antiplatelet agent or an anticoagulant to make the blood less sticky. And if you've got a big buildup of plaque, we may be able to get it out of there surgically. So we hope to prevent strokes, but when they occur, we want people to call 911 and get into the emergency room immediately. Because if you're in the midst of having a stroke, which is a blood clot sitting here, the other name is thrombus, we need to treat it. So how could you treat it if somebody had a stroke that happened 15 minutes ago and they rushed into the emergency room? TPA, what's that?
You've got a window of like 3 hours.
Got a window of like 3 hours to give TPA. TPA is like Drano for the brain, right? It is a clot buster. It dissolves blood clots. So it would make a lot of sense that if a stroke is caused by a blood clot, like 85% of them are, that if you could dissolve that clot and make it disappear quickly, that you could make the patient better. So TPA is a clot dissolver. It's made by Genentech just up the road, and that is the mainstay of treatment. That was the first treatment ever proven to be effective for stroke. The amount of injury that's going to happen from the stroke is going to depend how long the blood vessel is blocked by the clot and how good the collateral flow is, right? So if you have other blood vessels who are helping out, then the stroke will progress much more slowly. So again, we hope that we have good collateral flow if we ever have a stroke. We also hope that that clot can be dissolved quickly. So TPA stands for Tissue Plasminogen Activator. And what that is that in everybody's blood, they have something called plasminogen, which is basically a key that can unlock a clot. And if you activate that plasminogen, it will start to tear these ropes apart that are the meshwork of a clot. The ropes are called fibrin. So when you activate the plasminogen to something called plasmin, it starts to eat away at these little ropes and it can dissolve the clot. So your own system is going to try to do it on their own, but if it's a big clot, probably won't be able to dissolve it on your own. And you probably won't have a TIA. You'll need some help from more TPA to dissolve that clot. So the FDA, just as you mentioned, said we have 3 hours to give it. So the approval of the FDA is that we can give it if somebody shows up and we can get it into them within 3 hours. When they come to the ER, we have to take a picture of the brain. Because you can imagine if you have one of those bleeding strokes, the worst thing you could do would be to give TPA. They're already bleeding in the brain. You don't want to give a clot-dissolving medicine. So it means we got to get a picture of the brain. We have to do some blood tests. We have to check what's going on. Even if things go very quickly in the ER, that typically is going to take at least 45 minutes to do all those things you need to do. So a 3-hour treatment window means the patient better have arrived within 2 hours of when the symptoms started, or we can't give it, right? So if you woke up with the symptoms, we don't know when it started, right? If nobody was there to call 911, we don't know when it was started. So this is the biggest problem. We have a very tight treatment window. There have been studies that show that TPA actually works out to about 4.5 or 5 hours. And in Europe, the equivalent of the FDA has approved it to 4.5 hours. So at Stanford and many other stroke centers, even though our FDA says 3 hours, we'll go out to about 4.5, 5 hours with TPA. But we're doing this against the advice of the FDA because they say give it very, very early. But that means that only about 5% of stroke patients are going to get it because they don't come in soon enough. We've done a study here at Stanford showing very nice benefit of TPA out to 6 hours if you can take a picture of the brain and show that the stroke has not gotten very big in that 6 hours. So this is called penumbral imaging. The penumbra means the part of the brain that is likely to die over the next few hours but is not yet dead. So to be able to get to this, we developed an MRI sequence called diffusion imaging. It was one of the Stanford faculty members who discovered this MRI technique, which allows you to see the stroke as it's occurring. Before that, we would just do CT scans, and a CT scan doesn't show up the stroke usually for 6, 8, 10 hours. It's too late. So we want to see the stroke as it's developing. So with this technique, you can see this pink area is the tissue that is irreversibly injured. It's dead. But the green area is the tissue that's likely to die over the next several hours. So if a patient comes in like this one at 6 hours after symptom onset, and they have a small amount of tissue that's irreversibly injured, but a large amount that is still salvageable, we call that a large penumbra. It means that there's areas to save, salvageable tissue. And for these patients, we're going to be very aggressive. We're going to try to get that blood clot dissolved, even though they're beyond the approved window for TPA. So we can give TPA a little bit longer than it's approved, or we can physically go after the clot. And the first mechanical device to be approved by the FDA to pull clots out of the brain was this MERCI Retriever. This was from a company in Mountain View called Concentric, which has subsequently been sold to Stryker. So both TPA and this first approved mechanical device are local Bay Area products. So the person who developed this was actually a French neuroradiologist, and you can imagine was thinking maybe a little bit about wine and how you get the cork out of a wine bottle. It's kind of the same idea of how you get a blood clot out of a blood vessel. So this catheter is a tube that you're going to put all the way up into the brain, and you're going to try to get this corkscrew-like device into the clot. So here's a blood clot in the brain. You bring this wire up by putting it through a blood vessel in the leg, all the way up into the brain, and it turns into a corkscrew. You try to screw it into the clot, get a hold of the clot, and then pull it out. And this was the first device. We now have more sophisticated devices that don't look like corkscrews, but basically do the same thing. They go up into the brain, they capture the clot, and they bring it out. Those devices have approvals out to 8 hours. So it gives us more time, but still many patients don't come into the emergency room until the next day, right? They think they slept on their arm wrong, and then they wait till it doesn't get better the next day. They call their primary care doctor and say, hey, my arm doesn't move. They say, go to the ER, but it's too late. Okay, we're going to end, and we're going to end with this case study. This is a patient I had a few years ago, a 45-year-old man who was recovering from a surgical procedure at Stanford, and he was there in the room with his wife when he had the abrupt onset of left-sided paralysis, and he was confused. So where do you think the problem might be? Right side of his brain, yeah. Yeah, he didn't recognize that he was having a stroke. Okay, so it was, again, that area of the brain, the parietal lobe, where you don't recognize that he knew something was going on, and you'll see in the video that he was aware. But his wife was on top of it and alerted the staff immediately that something was up with her husband. Now, what do you think the treatment option might be? Strokes up at the top, yeah, on the right side. You want to give somebody like this TPA? Why not? Just had a surgical procedure, right? So TPA, you have to think carefully before you give it, because TPA can be a double-edged sword, right? It can cause bleeding as well as dissolve a blood clot. So somebody who's either already got a big stroke or who has just had a surgical procedure, TPA could be a problem. So what other option would you have that wouldn't involve TPA? Yeah, one of these clot removal devices. And this was a patient who was in the hospital very shortly after that corkscrew-like catheter was approved. So the patient went straight to the cath lab. They pulled it out, and he got all better from the stroke. So dramatic recovery. And let me show you the video so you can look at the different perspective of the patient and his wife.
Looking at him, you could just tell instantly that his face was dazed.
Can you hear?
I could tell his left side was whack, and I knew in my heart that I was thinking stroke.
Coming out of the stroke, I definitely felt there was an event, something had happened. I didn't feel completely paralyzed. I just felt like I'd been stunned, like I'd been shocked or jolted or something like that. My speech was felt a little slurred, and it was labored. I felt tired, and they did a lot of testing on what I felt, and the tactile sensation seemed to be okay. Every place on my body seemed like I could do that. It was just the motor skills were definitely a little bit of a challenge.
It's not good that you had the stroke, but we sure had a stroke of luck to be here. And, where we were, it was like he had little angels on his shoulder or something.
So he was completely paralyzed. And did you hear his description? A little problem with my hand, a little motor problem. So again, it's he's never would have called 911, even though he's completely paralyzed on the left side. So it is time for some questions or comments. Yeah, go ahead.
What is the reason for the 3-hour window during which you have to give the clot buster? What goes wrong if you give it too late?
Yeah, so that's a great question. The question is, what's this 3-hour window business? Why are we being so restricted? And we don't like being restricted. The reason for the 3-hour window is because there were big studies done using the 3-hour window back in 1995, showing benefit of patients treated up to 3 hours. And subsequent studies that have looked at later time windows have not been as positive. As I said, there was a big European study that showed benefit to 4.5. So we don't like to treat stroke based on time because everybody's brain is different, particularly the collaterals. So we see patients like this one that I showed you here, who at 6 hours had TPA and had this clot dissolved and had a fantastic recovery from the stroke. Because this patient had good collaterals and only little damage was done by 6 hours. We also see patients who at 1.5 hours have massive damage. So TPA will not help them. They came in within the 3-hour window, but the damage was already done. So we need a different approach rather than TPA. So the arbitrary time windows we don't like. And what we've been doing is studies to try to show that it makes a lot more sense to look at the brain with sophisticated imaging and then try to figure out who has salvageable tissue. So if you wake up with a stroke and come to Stanford and we take a picture and it looks like this, we're going to go after that blood clot. If you show up 2 hours into the stroke and the tissue is already massively injured, we're not going to remove the blood clot. We're going to try to do something to reduce the swelling, because a big stroke, it's going to cause even more trouble from the swelling. So it's a great question, but that's the rule of the FDA. Yeah?
There are no studies to notice genetic differences between people that would say some people need more cholesterol than other people.
No. There's really not some people who need more. There was some concern that if you have very little cholesterol, that your blood vessels may be a little bit more likely to cause a hemorrhage. And there is some evidence that if you look at some Asian populations who tend to run very low cholesterol, that they may have slightly higher brain hemorrhage rates. But when you look at the studies that use the high dose of the statin versus a medium dose, both for heart attack and for stroke, the lower the cholesterol goes, the lower the stroke rate. It's like the blood pressure. The lower, the better. So there may be some point, you can't go down to 0, right? It's like the blood pressure. You can't go too low. But in general, what we found from the studies is lower cholesterol is lower heart attack and stroke rates.
So how low is it?
The goal for somebody varies on what their situation is. But if you've had a stroke from atherosclerosis, that we want to get down below 80 on what's called the LDL, the low density, right? The LDL, the bad cholesterol. The HDL, you want to get it as high as possible. Yeah.
PSD, postprandial syncope. I was diagnosed several years ago. Nothing can be done about it. I had confidence in the doctor. And if I eat only a small portion of something, even a small carrot, I pass out.
Yeah. So the question is that passing out after eating, so postprandial syncope, that's not a stroke, but it is a problem which can be difficult to treat. And usually it's eating multiple small meals to try to deal with that.
Will it get worse? worse?
You know, it's difficult to comment about individual people's medical problems from the podium, but usually it doesn't get worse. It's usually something that can be managed. Yeah. Okay. Up front.
Yeah, there was a team some years ago at University of Iowa, ophthalmologists who looked at ischemic optic neuropathy and found that it correlated actually with too little blood pressure in the optic artery, causing a loss of blood flow. The blood vessel itself collapsed. And they showed that the coupling of taking an antihypertensive when going to bed with the natural diurnal rise and fall of the blood pressure, that was the worst time to be taking a medication like that. And it seems that when I mention this to people in the medical profession, most people, oh, that's new to me. I've never heard of that. And I'm wondering whether anybody is looking at these 30% of cases that are idiopathic, whether there's any chance that there was a blood vessel in the brain that actually collapsed because diurnal blood pressure drop and medication with a strong antihypertensive at the same time actually caused blood pressure to drop and blood flow to the brain to be cut off, to that part of the brain to be cut off because there wasn't sufficient blood in the vessel.
Yeah. So it's a complicated question, but what's being asked is that we talk about blood pressure being too high as a cause of stroke. Can blood pressure being too low be a cause of stroke as well? And the answer is yes, that there certainly are situations, particularly for patients who have major blockages of vessels where the plumbing is blocked up. You can imagine if you don't have enough pressure, you're going to run into trouble. And typically the type of strokes we see from that are called watershed strokes, where you have two major vessels and in between them is going to be the area of low flow, just like if you have two sprinklers, right? And you turn down the pressure, you're going to get a dry area in between. So there are issues, and like most things, there's an advantage and a disadvantage. You do not want blood pressure to go too low under certain circumstances. And the other part of the question was the timing of blood pressure medicines, which is very important. What you can do is a 24-hour blood pressure monitor, and sometimes it'll be very surprising to see that over the course of the day, things are fluctuating a lot. And just taking a blood pressure in the office can be very misleading. Oftentimes people's blood pressure is quite high when they go in because we're scary with our white coats on. So it can be helpful, and planning out how to give the blood pressure medicine certainly is an important issue. In the back.
A year ago I had a TIA, and well, I went in for that, and but the two doctors disagreed. They said, one said it was probably a TIA based upon all the MRI, all the imaging, and the other one said it's something encephalopathy. So they weren't clear. So in that case, where does that fall?
Yeah, it's a great question. So the question is, had symptoms that may or may not have been a TIA. The doctors didn't agree. That is not unusual. With a stroke, it's pretty easy to say yes or no, because the picture will say, is there brain injury or not? TIA, no brain injury. So there are lots of things that can mimic it. The good news is that most of those treatments for a TIA are things that we should all do, whether we've had a TIA or not, right? Blood pressure under control, cholesterol under control, taking an aspirin is a pretty benign approach. So it is not unusual to have controversies. Even neurologists will disagree. Even stroke specialists who see a patient, they cannot agree on TIA. If you image it at the time, you can look at the blood flow and actually see a blood flow reduction. But that doesn't happen very often, that you're in and get the picture in the midst of the TIA or right afterwards, where we may see a footprint of that blood pressure reduction. So not unusual. But the type of things that you're going to do after a TIA are good things to do anyway.
Yeah. Tiny little microscopic damage is what they said.
Yeah.
That's all they could see from the image.
Yeah. Yes?
Does every ER have TPA, or do you have to go to a stroke center?
Great question. Does every ER have TPA? And many years ago, the answer was certainly no, that people were slow to adopt TPA because it was a big change from what they were used to doing, all this rushing around. Stroke patients, there was no treatment. They were like the last priority. So in the Bay Area, most of the hospitals now are what are called primary stroke centers, meaning that they have TPA and they have a plan And then some stroke centers have the comprehensive designation, meaning they can go up with catheters and do fancier imaging. So in our area, we're pretty lucky that if you call 911 at this point, it's almost certain that the hospital you're going to go to is TPA ready. That wasn't the case a decade ago.
How is it being administered, TPA?
TPA is typically administered, the question is how's TPA administered? Typically it's just given by vein, intravenous infusion. Sometimes when we go up there with one of those catheters, you try to pull out the clot and little pieces break loose, and then we'll squirt some TPA to get the smaller clot. So it can be administered directly up into the clot in the brain, but typically it's through the vein. Question in the back there? Yes, go ahead.
I have high cholesterol, so I take Lipitor. Just wondering, is there a difference between the name brand or generic?
Yeah, question is for the statin agents, does it matter if it's name brand or generic? There doesn't seem to be a key difference there, so I think the generic is fine. Far in the back.
So the catheter is inserted from the leg?
Yes, it's inserted in, the question is where is the catheter inserted? It's inserted in the femoral artery and then up into the brain.
From the leg, inserted from the leg?
Yes, so the femoral artery is right next to the groin area, so it's the top of the leg where you get that blood vessel.
To save time, it cannot be inserted anywhere in the upper part of the body.
Yeah, so the question, can you go elsewhere? It doesn't really take any time to push it from the leg up to the brain versus the arm, and it's easier, it's a bigger target, it's a little safer to go into the leg than the arm. But if the leg is all blocked up, you can go into the arm. Years ago, when they first tried to do this, they went through the neck. That didn't go so well up front.
I'm interested in, you mentioned there's some new alternatives to Coumadin or warfarin. Are those discrete situations that they would be used in, or should many Coumadin people be thinking about going on to those? And secondly, do the hospitals in our area generally have those other alternatives?
Yeah, so the question about these new anticoagulants, and there are four. So some insurance will cover one versus the other. The first one on the market was called Pradaxa. You probably heard about that one. Most hospitals are going to have access to that, and many will have the other ones that have come out more recently. So these are typically for patients with atrial fibrillation. They have not been shown to be effective for people who have heart valve problems, like a mechanical heart valve. So it kind of depends on the reason that somebody's on Coumadin. If they're on for atrial fibrillation and they're having some trouble with the Coumadin, there's these offer some advantages. For somebody who has a stroke from atrial fibrillation, most doctors now would be talking about using one of these newer agents rather than going with Coumadin, because you don't have to do the frequent blood tests. There's not so much in the way of food and drug interactions, so they're much more convenient for the patient. Back there. Yeah, you. Sorry, I don't know anybody's name.
I've heard something about people can get like mini strokes that can lead to dementia. Does that make any sense?
Yeah, so the question is, can mini strokes lead to dementia? So a TIA doesn't lead to dementia because, as we said, by definition, a TIA doesn't damage the brain. But little tiny strokes, they can lead to dementia. So dementia being a lack of cognitive ability. So you can imagine if you're starting to knock off lots of little spots, the connections between different areas of the brain are going to be affected. Those typically occur, again, in people with high blood pressure, that the small little blood vessels deep in the brain get narrowed, and you start to get these little tiny strokes that people often call lacunar strokes, and they can cause dementia. So we don't want those to build up if we can prevent it. Second row there. Yeah, go ahead.
What's the story about omega-3? Does it really help with the cholesterol? Is there a benefit to take it?
Yeah, so the question is about omega-3, and that's been a controversial area. We find that the statins have much more evidence to support them. So we would recommend the statin agents. The guidelines recommend the statins over the omega-3. Question over there. Have we expired our time? I think one more question. Okay.
Did I hear you say that the new anticoagulants are easier to regulate? I have friends who have gone on Coumadin and have trouble, getting it to the right level. Are the new ones easier to?
Yeah, so the final question is about these new anticoagulants, and are they easier to regulate in the Coumadin? And they are definitely easier to regulate. They were all tested, all four of them, in huge trials, where one half took Coumadin and had all the regulation issues, and the other half took these new medicines with no regulation. Okay, so you weren't upping and adjusting the dose like you have to do with Coumadin. And all 4 of these, were either as good or better than Coumadin in these big trials. So they were as good or better without all that regulation. So somebody whose blood thinning is jumping all over the place on Coumadin, these are much smoother. Now, the disadvantage is that we don't have great tests to monitor how much is in the blood. With Coumadin, we can tell exactly how much is in there with a blood test. The newer agents, that's a little bit trickier. And then there's a little bit of an issue with reversal of these newer agents. That Coumadin is hard to reverse also, but we have medicines with a lot more experience reversing Coumadin if somebody comes in bleeding. But overall, patients typically did better with these newer agents. So I think we have reached the end. Thank you very much for coming. I appreciate all the fantastic questions. Sure.